Students, this recording is going to be for your IV therapy, chapter 9. The title of this chapter is going to say Complications of Infusion Therapy, Peripheral and Central Vascular Access Devices. Again, this is going to be chapter 9 in IV therapy. So we've already talked a lot about kind of peripheral lines. We've talked a little bit about central lines. We've talked about the management and care of both of those systems, kind of why patients need them, some of the medications that go through them. So now we're going to circle back to the use of peripheral and central vascular access devices with the understanding that sometimes these lines have complications. So a complication meaning that something has gone wrong with the line or the system. So therefore, as nurses, you have to be able to identify these causes in order to take care of your patient. Okay. So terms that you're going to have to know, because we always start with our glossary. So our terms to know. The first one are associated bloodstream infection, which is also known as a CAPSI, catheter malposition, catheter occlusion, embolism, extravasation, hematoma, infiltration, phlebitis, pulmonary edema, sepsis, thrombophlebitis, thrombosis, venipuncture, and vesicant. So those are going to be the terms that you really do need to kind of understand, and we'll talk a little bit about them in between the chapter. So if you go to page 421, it talks about the introduction. It says the placement and presence of the vascular access device puts patient at risk, right? So for complications, that's not just while they have the line, that also is the risk that happens before the line is put in. Also keeping in mind that when the lines come out, patients aren't free and clear of infection because they still have a hole in their body. So until that hole completely closes without any issues, there's always going to be a risk. This is kind of the reason why we try not to stick patients multiple times, because the more times you stick them, you're introducing or opening up a new area where pathogens can get through. So for you as a nurse, just understand the risk is there at any point in time. And risk could mean like a local complication or a systemic complication. So your local complications will be like your phlebitis, it'll be infiltration. Those are more of like your local complications, but your systemic complications is always going to end up involving the whole body in itself. So that'll be like your CAPSIs, okay, your central associated bloodstream infection. So it goes to the whole body. So what we want to do is we try to prevent this from occurring. So we have to go back to our original techniques with maintaining antiseptic techniques and using our ANTT techniques to make sure only certain pieces touch after we clean them. We're going to make sure we use the right cleansing agents and use it as far as the manufacturer's guidelines have been given to us. That's how we're going to minimize the risk for infection. So that's going to be cleansing the skin, cleansing the site to prep it for insertion. It's also going to be maintaining the line once it's been put into the patient and cleansing the hubs as well before we insert or put any kind of uh, product into the line. So for you as nurses, if you look below figure 9.1, it says the educated nurse understands potential complications, signs and symptoms, prevention. All these things are true. So if you truly are a nurse caring for patients with these IV lines, it is your job and your duty to understand and recognize these symptoms that are going to come up. Um, with our patient population being majority of them being older adults, we need to understand that there's a higher risk for your older adult population because of their skin and vein fragility that can occur. So you always want to make sure that you're increasing how you monitor those patients that are more high risk. So for your relatively healthy adult patient, yes, we want to monitor them, but for our patients that are high risk population, like your older adult, compromised patients, you're going to check them more frequently. Even patients like in the critical care spaces, you're going to check them more frequently. Okay. According to your INS standards, this is one of those governing bodies over infusion therapy. When we do not need the lines, we take them out. And that holds true not just for your central lines, it holds true for your peripheral lines as well. When they're no longer necessary, you need to remove them. The longer they stay in a patient, the higher risk for them to have a catheter-associated infection, just because over time, people changing the dressings, the line getting manipulated, us hooking up infusions, disconnecting infusions, and if everybody's not using the same technique, pathogens will get in. So as soon as it becomes where you do not need this line anymore, it's always best just to go ahead and take it out from your patient. All right, let's look where it talks about local complications. So your local complications always starts with your venipuncture. So your venipuncture is where you stick the patient, right? You're going to stick the patient. You're going to get a positive blood return if you're successful with your stick. And once you stick them, that also opens up the point of where they can end up with some type of infection. So your venipuncture site is always going to be one of those areas that is always a risk factor for patients to get some type of pathogen introduced into their system that was not there before. So you always want to make sure that you're following facilities guidelines. You want to make sure that you are cleansing the site with the right products that the facility has given you and that you follow those manufacturing guidelines. Other things that we have to think of as far as local complications is something called a hematoma. That hematoma is another way of saying ecchymosis. They're kind of used interchangeably for the most part. So hematoma is the swelling of a area, right? It's going to be a blood-filled blister for the most part. It's going to be a raised area, nice big blood-filled. So what happens once that hematoma kind of ruptures or once things settle down, sometimes the blood will leak into the tissues, and that's what causes that bruising and or what we know it as ecchymosis. Okay? So make sure you understand um, that they kind of go hand in hand, but a hematoma really is just when you have a huge area or site that's just filled with blood. But once the blood goes through the tissues, and sometimes it doesn't look so pretty, it'll leave bruising, and that's more of your ecchymosis. Even if you don't have that blood-filled space, if we don't do our venipunctures correctly, we can cause hematoma too. Okay? Or not a hematoma, ecchymosis as well. So going back to some of the reasons, which you will see under the descriptions of and etiology of a hematoma, if you don't do your venipunctures right, like I've said, if you have an IV cannula, that cannula is like those we talked about the 20, 22, 24s, all those different size gauges with all the colors on it. The opening is the cannula. So if it's too big, it can rupture the vein, which can cause it to form that hematoma. If the tourniquet's on fragile skin, it's too tight, it could cause a hematoma. So you just want to keep that in mind as you are navigating, trying to put in your lines in your patients. So signs and symptoms, you'll see that discoloration, you'll see the swelling to the site. You might meet some resistance when you're flushing. If you have your textbook, if you look at page, for me, it looks like page 425, but y'all might be on 424. So right below the signs and symptoms, you'll see an image, figure 9-2, it says hematoma. That's exactly what it looks like. It's kind of a raised area. It's very large in nature most of the time, and it looks really nasty and bruised. So that can occur just from us not following our proper guidelines and techniques. So how are we going to prevent this from happening? We try to make sure that we use a direct approach when we're starting an IV. So you need to know where you're going. Go in one time, go in a nice clean swoop, and the chances of you causing that vein to rupture or blow or make a hematoma is going to be limited. You might want to use that visualization technology, right? The vein finders to help you identify where veins are if you're not able to see them. We do not leave tourniquets on for long durations of time. That increased pressure can cause a hematoma. Your gauge size that you select, especially again, older adults, immunocompromised patients, those that are high risk populations, choose a smaller gauge size if it makes sense for what's needed for the patient. Generally speaking, that does make it easier on their veins. And of course, we always want to be nice and easy when we go in. If you come across a patient with a hematoma, how are you going to take care of them? One thing you need to do is just understand that we need to get the IV removed if there's an IV in there, and then we want to elevate. There's a fluid-filled space, right? It's a trapped fluid that's there, and hematoma just means blood-filled. So you want to put light pressure and elevate in ice. Light pressure, elevate, ice is a treatment for your hematoma. If something is swollen, we use ice. So do not forget that. Documentation, of course, if you end up creating a hematoma or ecchymosis, you need to document. Phlebitis and thrombophlebitis. So phlebitis is inflammation of the vein. Thrombophlebitis is a blood clot within the vein. Do not mix the two up, okay? So these do occur from having just vein damage. If we give certain types of medications and we're not mindful of what we're administering, like you have some of your antibiotics, things like potassium with electrolyte imbalances, you have some medications that are used for blood pressure control. Those are a little bit more viscous. So if we're not careful with how we manipulate the lines or how we manage the lines, we can cause chemical damage to our patients, and they can have issues from these meds and drugs that are given. Okay. So when you go down to your note, if you look on page 425, for me, it's a note. It says that it has been suggested that phlebitis is based on symptoms, right? So it tells you what those symptoms are. Phlebitis is a local infection, okay? So, yeah, a local complication, I'll say, not necessarily infection, but a local complication. So, you have erythema, which is the redness. It'll be warm to the touch. It'll be painful to the sight as well. So when you see those signs, that generally is your phlebitis. So we want to make sure we take care of that as quickly as possible. All right. Go down to table 9-1. It says types of phlebitis. You have mechanical and chemical phlebitis. Be familiar with those, and bacterial phlebitis. Um, it's just the reason why there's different variations is because some ways and techniques that we do result in phlebitis as a whole. But because of those ways, techniques, or medications that are used determines if it's mechanical, chemical, or bacterial related. So if it's bacterial related, then that means that we didn't do our job with keeping things clean. We have to keep the drainage away from the site. We got to make sure it stays clean, dry, and intact. And if it's chemical, it's usually related to some type of medication or infusant that was put in. If it's mechanical, that's just all about how our technique is when we're putting in these lines. So make sure you understand the differences between the three ways. Look at your nursing fast fact. It always goes back to that ANTT technique and your equipment, making sure that you're doing your proper assessment on the patient. If they have like a lot of hair on their arm or their skin in general, and that's where you want to go, you might want to remove that excess hair because those hair follicles can become inflamed, and that could be a reason why the lines get infected. Okay. In the event that people do have complications from getting phlebitis and that they have an inflamed vein, generally speaking, it can occur even once you take it out of the patient's body. So post removal, like your textbook says, the highest risk is when we go in at the very beginning, if you don't manage the lines throughout the duration of it. But there's also a risk factor that's involved with phlebitis even when you take the line out. So if you're going to see a complication with the vein becoming, it's generally going to happen within 48 hours after the vein has been, after the IV line has been removed. Okay. So please, please, please make sure you always check your patients. Always check and double check your patients. Signs and symptoms of phlebitis. For me, I am on page 427. Again, that erythema, it's going to be painful to the touch. You'll see a little bit of swelling, but the biggest thing that you're going to notice is that it has like a cord-like feeling to it. It feels like a cord is like a literal cord is under their skin. It's very hard. So that streak cord-like sensation is what is going to identify itself automatically as phlebitis. People who have fair skin, you might see it. People who do not have fair skin or lighter skin and do have darker skin, you might not see the cord, but when you put your hands on it, you can feel it. Okay? How are we going to keep this from happening? Prevention. When there's an issue, there's got to be some way to help us keep it from occurring. So we have to do our assessment. Always check, 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 and make sure things are clean, dry, and intact, and make sure you use your proper ANTT technique. All right. So go down below chart 9-2, and you'll see some, looks like a letter and then some numbers. It'll start with like number 3, 4, 5, and 6, and then it goes into some letters as well. It's right under prevention. So we did start with the prevention section. So if you look just below that table 9-2, there's some more numbers. I need you to notice those numbers. We've already talked about when we're putting in IVs, we try to avoid areas where things can bend or twist relatively easy because that puts patients at risk again for complications like phlebitis or infiltration, which we'll talk about in a little bit. But make sure you understand what phlebitis is. Make sure your sites are secured. Make sure you're monitoring for complications every 4 hours. Again, if you're on a general floor, every 4 hours. Critical spaces, 1 to 2 hours. If you're dealing with high risk meds, 1 to 2 hours is what needs to be documented so that you can actually say that you've been in to assess your patient. Um, if you find that you have neurological changes in your patients after the IVs have been placed, you need to go back in and reassess them as well. So it doesn't just stop with putting in the IV and letting them be. No, we always have to keep going back in and definitely reassessing every time. So that would be an example with the neurological changes. If you're using some type of sedative, you want to go in and reassess really every 1 to 2 hours. And you're checking the site, you're checking your patient, you're checking the medicine, everything gets assessed. Documentation, we've already spoke to that. You're going to document all observable symptoms, and that includes your subjective data as well. Okay, so your objective data would be more of your observable symptoms, and subjective data is what the patient states or feels. So we always go in and ask them, how do you feel? Is everything okay? Do you need anything? We have that conversation, and we're always checking the line. You run your hands over it lightly just to make sure, above the site and below the site, just to make sure there's no complications with your line. Okay. When we are prepping, we've seen this before. It reiterates it in documentation under your nursing fast facts. When we're prepping the site with the antiseptic, we don't blow on it. We don't touch it once it's done. It needs to sit and dry. Okay. Otherwise, we're cross contaminating our line. All right. Infiltration and extravasation. So you'll see that starting on page 430. And it's going to let you know that infiltration or extravasation is where it starts to impact the tissues. Okay. So the main difference is that with your infiltration, generally speaking, it's not related to a vesicant. So your infiltration is, again, not usually related to some type of vesicant. A vesicant meaning some type of very strong chemical or a medication that's put into the patient that's causing them to have a complication with things going into those tissues. So vesicants cause damage. They cause where the tissues can get destroyed or ate away. So that's what your vesicants do. An example will be your potassium or some of your or other really strong potent drugs like amiodarone if it's a cardiac drug that you have to give. Those are more of your vesicants. So for us as nurses, you have to recognize what you're hanging up. You've got to pay attention to the drugs. You've got to know your meds. So understanding pharm is just as important when you're dealing with IV infusions because they technically go hand in hand. If you got a patient that has a need for something, like with a patient who has electrolyte imbalances and we have to hang up potassium, we're not going to put the IV in the AC. We're not going to put the IV in the wrist. We try to stay in the middle space of the forearm or go up higher above the AC. When we run that potassium is considered a vesicant. So we have to make sure that when we hook it up, that our IV was good, it was clean, it was dry as intact, it was patent. There was no issues or complications prior to hanging up that infusion. And once you hang up that infusion, you've got to go in and check and double check and reassess every so many hours just to make sure the patient's not having any issues. But again, if it's just normal saline and then the patient complains of having a puffy arm and it's cold to the touch, then that is considered infiltration. And again, it goes into the tissues just like extravasation goes into the tissues, but you're not dealing with a medication that is considered a vesicant. So vesicants lead to extravasation. And then non-vesicants generally results in infiltration if it's not managed appropriately. Okay. Um, go down to, yeah, we've talked about those things. If you look at the image 9-3, this is from vancomycin. This person has tons of blisters all over their skin, and it's not does not look good at all for them. That is an example of extravasation. So they have tissue damage. This is infiltration, but it's tissue damage at this point, and it's from vancomycin. So that blistering is not something that is ideal for that type of medication. Generally speaking, when they get to evisceration, they do damage to where it's more permanent. And so that permanent damage that's done to the tissues can result them having to have surgery or potentially may have resulted in having musculoskeletal damage or nerve damage. Go to 9-4. You'll see a picture right below 9-2. That's another picture of this one says extravasation. So the first one is more of your infiltration related to vancomycin. Now, granted, they have all those blisters and they're clear. So most of those blisters will probably resolve on their own with minimal scarring or minimal damage. So that is why they consider that infiltration. It's not permanent. But with the second picture, you can see where their skin is indented. That's not going to recover. So they're going to have some type of plastics come in to look at them and see if they want to uh, reinvent how their skin looks because that's not going to heal on its own. Okay. So nursing fast fact on page 433, it tells you not to take a blood pressure where there's an IV site. We have talked about that before. We do not take blood pressures where there's an IV site. We also have to consider um, when we are managing the lines that there's nothing that's occluding the lines or we don't leave tourniquets on for too long while we're trying to use the lines because that's just going to increase the risk of those complications like infiltration or extravasation. Your signs and symptoms of infiltration are going to be where the arm in most cases or the hand wherever the IV is going to be cool to the touch. When you touch the skin, it might blanch or it could be very taut. Taut means tight. So you'll know it's infiltrated because when you push down on the skin, it might change colors. You'll see that fluid kind of dissipate within the skin and then the color will return. Or it'll be tight where it's so swelled up that it feels like a kind of like a balloon full of air, but balloons aren't very tight. But if you think of like a basketball, you fill it up with a bunch of air, it's very firm. So that's kind of an idea of taut. So if the patient starts saying that they are having discomfort and their arm feels kind of heavy, you might want to go in and assess. If they're complaining of pain or burning at the site, you need to go in to assess. When you put in an IV, it should not burn your patients. Patients shouldn't have any issues with the IV. It should just feel nice and cool. Yes, this does say that if cool temperature changes means that it could be infiltration. That is true, but there's more than just a cool touch that comes with infiltration. They'll have the edema, they'll have which will lead to the tautness, or they'll have the burning sensation or some discomfort at the site. Having a cool touch to the skin does not mean it's infiltrated. Oftentimes with our used in is naturally going to be cooler than the rest of their body. So the coolness alone is not indicative of a complication. The coolness could signify that it is a normal response to the medication. So don't mix those concepts up. Patients will have decreased mobility as well, and you'll notice that the infusion might not flow as nice and smooth either. Sometimes it'll leak around the site that the actual IV is in as well. So again, coolness alone is not a complication. That's usually an expected finding, but coolness with some of these other findings will identify infiltration. Okay. So what we want to do is just when we notice infiltration, obviously you're not going to be able to save that IV. Same kind of concept with extravasation. The difference is it could lead to ulcerations or tissue damage because in most cases with extravasation, it's going to be permanent. And it is permanent because of the chemicals or medications that are used that cause that tissue damage. Okay. Compartment syndrome can happen for patients that have either one of these two complications. And all that's telling you again, infiltration, extravasation is going into the tissues. So if you have a lot of fluid that's going into the tissues and nobody's taking care of that, it puts pressure onto the nerves. If it's putting pressure onto the nerves, it can lead to things like compartment syndrome. And that means that they now have a whole bunch of fluid that's accumulated around those vessels and it's cutting off the circulation. So patients will feel like a lot of muscle tightness. You might notice changes in their blood pressure, their capillary refill might be compromised. So just think about what that looks like long term. If you go down to not patient, figure 9-6, you'll see an example of what nerve damage can really do. Their skin is gone. It is severely damaged and it's led to nerve damage, which is permanent. So whoever this nurse is going to have a lot to answer for. And I don't know if they would have their license or they might be suspended until that's investigated. How are we going to keep this from happening? Your prevention is important. You want to always make sure you use your ANTT technique. You're always going to assess and reassess. We have to consider the type of medication that's going to be administered, the type of IV site that's being used for that medication. You want to make sure it's not in an area that bends or twists. And we don't usually go over more than a couple of attempts when we're trying to do um, an IV insertion. So keep these things in mind. Some of these same processes of prevention is what we use for multiple complications. So if you know that you're going to start an IV, you're going to pick a good site. You're going to make sure you get in one and done is better. You're going to monitor the site. You're going to make sure you know your drugs and your meds. You're going to follow up on your patients. Always assess the site, not just with your eyes. Run your hands over it. Make sure that it's actually not causing your patient any harm or discomfort. Okay. Treatment for these types of complications, the first thing we do, and I'm on page 438, stop our infusion. When we have a complication, we want to stop it, whether it's infiltration or exacerbation. You're going to talk to the doctor. You got to call them, let them know what happened. Most of the time with infiltration, if there's a non-vesicant and it was related to something like normal saline, and we didn't cause any significant things like compartment syndrome, but you know it's infiltrated because it was cool to the touch, it was painful, it was a little bit of edema. We would just remove the IV, we would elevate the arm, and we would go ahead and start a new IV. That's not necessarily a reason to call the doctor to let them know that. So if it's more of like a vesicant where the tissues have been damaged or potential nerve damage or musculoskeletal damage has been done, then you would need to notify the doctor. Okay, for our infiltration or exacerbation, warm or cold compresses can be appropriate. If it's edema, we obviously like the cold compresses because cold helps with vasoconstriction. But we might use heat as well if it's more pain at the site. We might use heat to kind of subside some of that discomfort that the patient is using. Of course, we elevate to help get fluid back into the vascular system as well. And we also teach our patients of what to monitor for. Ideally, that swelling should go down if it's infiltration. It might take a couple days depending how bad it is, but for the most part, a lot of that will just be reabsorbed by the body and go down. What we do not do is if we find that it has evisceration or infiltration is put pressure on the arm. It's very different than the treatment of a hematoma. So we do not put pressure on the arm. We don't wrap it up tight or anything. Just leave it as it is. You're going to document all the findings and you'll see them listed there on page 440. Okay, your nursing fast facts, there's several of them on page 440. We don't increase the flow rates when we are thinking of having patients that have infiltration. We don't just make things go faster to really test it out. That can cause more damage. And we want to make sure that we are using some type of stabilization device if it was needed to keep things from being manipulated. All right, that's some of the best ways to try to help keep our lines protected as well. Okay. Tissue damage, if it's prolonged, it can lead to infection or necrosis, and that leads to surgery. So those are some of the things we've already talked about. Nerve damage is just that. When you go in and you result in a response where the nerves have been impacted, they don't usually get that back. Once it's damaged, it generally is considered irreversible. Okay? So always keep that in mind when you're caring for your patients. Signs and symptoms of nerve damage. How will you know somebody's got nerve issues or nerve damage? Usually it's just sharp shooting pain. That sharp shooting sensation will either go up or down the arm, doesn't really matter. They might have some tingling in their fingertips or hands. That all is indicative of nerve damage. So for you as a nurse, you're going to have to make sure you're able to identify that, but making sure we keep that from happening. So we try not to go near areas where we're unsure if it's a vein or areas that are high risk areas that have a lot of nerve endings. We stay away from those. Okay, and that could be like your wrist areas, areas that bend and flex. We try to avoid them. Okay. Um, go down to let me see. I want you to go. Let's go down to catheter associated. Oh, sorry, I lost my spot here. So go down to where it says on page 47, systemic complications. Now, your systemic complications, these are more like your CAPSs, right? So your CAPSs are the ones that go and affect the whole body. So for us as nurses, we have to make sure that we understand again about how to prevent this from occurring. What do we need to do to keep our patients safe? A lot of it stems from your cleaning techniques and management of your lines. So you got to use the right uh, uh, equipment, meaning your cleansing agents, to make sure the skin is nice, clean, dry, and intact with your cleansing agents on it. Make sure they dry appropriately. Make sure that you're changing the dressings when they're supposed to be changed. Make sure you're using the right equipment provided by the facility, that nothing's expired, and you're going to monitor the site. That's how you're going to keep CAPSs down. All right. If something is not clean, dry, and intact to the skin, we need to take care of it right away to keep it protected. The biofilm that's over these lines, that's your tegaderm, essentially needs to be clean, dry, and intact. Okay. So you want to make sure that that stays in place, clean, dry, and intact. But understanding that sometimes the biofilm that does accumulate underneath the dressing in itself can lead to microorganisms thriving and growing. So that can lead to infection. How do we know that you have a local infection versus a systemic infection? Again, that erythema, the pain, the tenderness to the site, it's very specific to the one area, right? Well, where your systemic infections, it's going to have that impact in that site, but you'll also see fever, chills, nausea, vomiting. So again, systemic whole body system can be impacted versus only at one specific area. Okay, so get to know your signs and symptoms of a local versus the systemic. You will see them listed on page 448. Your nursing fast fact goes back to the concept of sepsis. We've talked a little bit about sepsis in the beginning, and sepsis treatment leads to time. Time meaning temperature, infection, mental changes, and illness. So if you see these things within your patient, you might want to start thinking, are they going septic? Okay, so sepsis equals time. So make sure you understand kind of what sepsis would look like. So these patients can have changes in their temperature, they can have changes in their mentation. For older adults, generally speaking, it's the mentation that will come with them first, even with not so much older adults, even regular adults that don't have any cognitive deficits to begin with will have mental changes. They might become slightly confused or forgetful or just feel very tired or drowsy. Um, they just don't feel like they have any energy. they'll complain of some discomfort, like they feel like they got the flu. They will look kind of cruddy. All right, they'll look cruddy. So you just want to make sure that you recognize those signs and symptoms. Again, it all really stems back from how you care and manage your lines. So you do have information that says before insertion, that's your pre-cannulation. What happens during insertion of a vascular access device, that's your cannulation technique. And then you have your post-insertion care and management, and that's your post-cannulation technique. So I need you to review those concepts that are listed there with all those red bullets. We have talked about them before when we were putting in a peripheral line, but they come back again when you're taking care of a patient with a central line. So our treatment when we're suspecting that someone has some type of bloodstream infection, you got to talk to the doctor. You have to notify them immediately, especially with the central vascular access device or a PIV. You need to talk to them because they're going to want to get sampling of whatever that drainage is around the site. If they think it's the infection is caused from the actual line, they want samples to have it sent off to the lab so they know what the treatment will need to be for that patient. Okay. If it's a central line that is suspected of causing a patient to have some type of bloodstream infection, we do not take those out. We culture them by taking some swabs and sending them off to the lab. If it's a peripheral line, we take it out. Okay, we don't even wait for the doc. We just take it out. Central lines, sample. Peripherals, we leave it in. Oh, peripherals, we take them out. Okay. Um, Once the culture has been done, the docs might order antibiotics. So because this patient had some type of infection, you don't know really where it was or the culprit behind it. So once you get your sampling done, you might want to cleanse it and put a new dressing on it. It's just better. And then you get new tubing. Get new tubing, hang everything up brand new. And so you're kind of starting over with the exception of taking the line out. If it's a PIV, you're going to do the same thing. Take it out, protect the site, start a new site, get new tubing so nothing is cross-contaminated over to the other space. All right. And then we just maintain it from there. All right. So go to, it talks about circulatory overload and fluid IV administration. This is circulatory overload, same thing as fluid volume overload, pulmonary edema, they all are interchanged. This is something we've talked about before. So your signs and symptoms of fluid volume overload, you need to know. How are you also going to prevent this from occurring? Okay, treatment that's involved. These are some of the same concepts we've talked about several times. So your circulatory overload, fluid volume overload, what are going to be your signs and symptoms of what people look like when they have a ton of fluid on their body. Okay. How are you going to keep that from happening? We don't want to speed up the IV because that could lead to fluid volume overload. We want to make sure that we're getting those daily weights on our patients. We got to recognize the symptoms of the treatment. Generally, will sometimes be to slow down the rate. And of course, we might stop it if they have significant changes like in their respiratory system or vital signs. Okay. We might have to give a diuretic. Sometimes when patients have too much fluid on their body, we have to give them a diuretic. And at the end of the day, we always end up having to document. Okay, document everything as far as the symptoms, the treatments, anything that's come up as far as the testing and diagnostics that may have been done. Document, document, document. Now we're going to move on to page 454. It's going to talk about air embolism. So we've mentioned about air embolisms before. This is a complication, but it is lethal, okay? For most of our patients, they can have a lethal issue result from having an air embolism. So this is just generally speaking, when you have air that gets into the line and that air can travel and it'll cause a blockage, okay, or a locked pocket of air within the vascular space. And of course, just like anything else that becomes an obstacle, it can result in a lack of blood flow or supply to that area. So people end up having like a heart attack or stroke or just instantaneous. Sometimes they will die depending on how significant it was. But it's from the lack of blood supply that's going to that area. Okay. So this can happen when we're putting in our IVs or central venous access devices. It also can happen if we don't prime our tubing, if we don't make sure that the catheters, when we take them out or put them in, is as a whole. So when you put them in, they should be as a whole system. When you take them out, you should have the tip intact because that can lead to things like an embolism. Signs and symptoms of an emboli are listed on page 455. These symptoms have not changed because you've learned about these in Med-Surg, but know your differences between your pulmonary embolism versus your DVT. Your pulmonary has a lot of respiratory issues, and you'll see like the cyanosis. You'll hear the cough, the wheeze, the edema. They might have weakness. You'll see, notice the pulse might be very weak, but it's very fast. Okay, so prevention is always important. You got to make sure you monitor the site, monitor the lines, make sure there's no air in it, clamp things off if they're not being used. Okay. Treatment pretty much kind of aligns with some of the preventative measures. If the patient ends up having a pulmonary embolism, it's going to be a medical emergency. It's not going to be much you can do to stop it, but you can put the patient on their left side, and it's going to keep air from going further up the right atrium. So you put them on their left side. You're going to put them in a Trendelenburg position. Again, we're trying to keep things away from the heart, slow it down from approaching to the heart, and you're going to put them on oxygen. You will need to notify the doctor if you suspect your patient has had a pulmonary embolism right in front of your eyes. You're going to have to notify the doctor. Okay? Let's go to some of the documentation that needs to be done as well with patients. Same thing. Document all your findings, what happened, what led up to it. Okay. Patients with these pulmonary embolisms can become unresponsive and very short of breath. So if they become unresponsive, your job is to initiate CPR. Okay. Let's go to, if you look at table 9-4, it tells you all the things we just talked about: hematoma, phlebitis, infiltration, nerve injury, local infection. It mentions all of these things, but it puts it in a nice, kind of like a packaged way. So if you like that version of it better, you can use that if it helps you to keep things more in alignment with what you need to learn. Nursing care, nursing points, your assessment, which is your data collection. Always get a baseline on your patient. You always need vital signs on them. You're always going to assess their skin. You're always going to assess the need for the line. Always know your drugs and make sure you're monitoring for adverse effects. Okay? Use your ANTT technique. Central vascular access device complications is not going to be much different than what we've already discussed before, but your book wants you to know that people can end up with a pneumothorax or a hemothorax. Your pneumothorax is where you have trauma in the lungs, okay? It's where you get air that's trapped into the pleural spaces. That little cavity, that's that lining that's around the lungs, that's your pleural space. So air gets into the pleural space. Hemothorax is where blood gets into that same space versus air. Okay? So signs and symptoms are going to be super important for you. Know your signs and symptoms of a pneumothorax versus your hemothorax. They're listed on page 463. One is resulting from blood, one is resulting from air deficiency. So you're going to see the signs are pretty distinct from one another. Okay, you'll see changes in color. They'll have some chest discomfort. They will be both tachycardia. And then you'll have hypotension because of where the blood is going into that space. It's leaving the vascular area. It's going into a cavity that it's not supposed to be. So you'll have changes in patients' blood pressure with your hemothorax. But your pneumothorax, there's a lot of respiratory issues. They'll have difficulty breathing, they'll have a cough, and their heart rate will be up. But you don't have any issues necessarily with blood pressure in those patients. It's a medical emergency. You're definitely going to notify the provider. You're going to monitor the vital signs and go from there, whatever the doctor decides he or she wants to do. Go to malposition, central vascular access device malposition. Malposition is just another fancy way of saying that it's not in the space that it's supposed to be. It's moved. Malposition means it's moved. Okay. So how do you know your IV is not where it needs to be? Um, you're definitely going to have issues when you try to prime it or flush it. You could have patients that present with pain or discomfort as well. So it's very important to kind of know where your central vascular access devices are. If they're not working right, we don't force them to try to make them work, because perhaps the site or the line has been where it did move. So if it's moved, we don't want to continue to try to manipulate that line. We want to get help as soon as possible. Only certain people can put in, your central line. Not everybody is trained to put those in. So if you're having any kind of complications related to your central line, most of the time for us as nurses, we just consult the IV team and they come up and they look at it, and they make the adjustments to help us out. Okay. BADs, look at your nursing fast fact on page 466, are always flushed and aspirated for blood before each infusion. So you should get positive blood return every time you use these lines, but it's not always guaranteed. All right. If you don't have blood return, then we have to follow a different protocol because that's what that line is designed for. You should be able to flush it and get a positive blood return. If they've got multiple lumens, we don't freak out as much about it, as long as one of them is giving us blood return. But if you've got multiple lumens and neither of them are giving any blood return, then we need to go ahead and consider getting some supportive measures where we can put chemicals into the line that will help dissolve whatever is causing it to be clotted off. Okay. So catheter occlusion is another reason to consider as far as why these central lines might have complications. And you'll know it's occluded because you won't be able to really get like a nice free flow of blood or fluid. It'll be very slow. So you'll be able to push it, but it's very slow to go in. Okay, that's going to be your catheter occlusion. It could be something as simple as it's clamped off or kinked off, or something's obstructing the site, is why the patients are having issues with being able to use their line. Okay, so you want to just make sure that the lines stay clear and patent at all times. Let's see. I want you to go to, make sure there's nothing else here. I need you to really understand. This is a relatively good sized chapter, so lots of helpful information is here. Okay. Go to the treatment section on page 471. So in the treatment section, it's going to give you some steps and tricks of how you kind of troubleshoot central venous access devices if you're not able to flush them. So there's a couple things that we do. Sometimes we reposition, have them cough. We might want to manipulate just a little bit of the line. Sometimes you can do that and it'll work. If it's kinked off, we undo the tubing just to make sure that it's not the reason for the obstruction. For your ports, those little implanted devices in the chest. If you get into the port and you don't get blood return, you take the Huber needle out and you have to go back in it again. Okay. So there's not a lot that you can do with a port, but for some of your central venous access devices, we usually will manipulate the arm, hold it down, hold it up, turn to the left, stand up, sit down. We have them do all kinds of crazy things. And believe it or not, some of those little tricks actually do work. Okay. Let's go to embolism. So that's going to start on page, it says catheter associated deep vein thrombus. So this is the kind of like the pulmonary embolism's best friend. Either it's going to be a DVT or pulmonary embolism. So go to where it talks about your signs and symptoms. And of course, right above that was just who's at risk for developing a DVT. But your signs and symptoms is what you need to be able to recognize as a nurse in treatment for these patients as well. Okay, so DVT, pulmonary embolism, relatively the same as far as treatment and process and monitoring, but your signs and symptoms is where things are going to be very different with each of these conditions. You also have a table 9-5 on page 475 that does speak to the concepts we just covered: pneumothorax versus hemothorax, catheter malposition. Okay, thrombus versus PE. So you again, your book is good about talking about the concepts, but it's also good about providing you with a chart if you need it. Okay. Um, you can review your nursing points of care when it comes to complications with central vascular access devices. That just starts with your nursing assessment pieces. Some of the same things we've already talked about, but you can review that again. We're not going to talk about the kiddos. Your nursing process does come back. It just is in a different way as far as how it's laid out, but you always start with your assessment of your patient first. And you want to address any concerns that they have. But we always assess our patient first. Okay. And that is going to conclude your chapter 9 recording. So make sure you do review the content that's in here. You can always look at your chapter highlights to help you kind of recap the chapter. The nursing process isn't going to change. It's something we've talked about several times before. It gives you nursing diagnoses, but for you all as licensed practical nurses, you do not create a care plan and formulate nursing diagnoses. You support the RN with the creation of the care plan. So your support will be more of like reporting things to him or her. Your support would be like adding to the care plan that's already put in place, follow-up care and treatment, things of that nature is what your role would be as a nurse. Okay. But this is going to conclude your chapter 9 recording for IV therapy.